IHPS idiopathic hypertrophic pyloric stenosis main pathology. Hypertrophy of circulation muscles in pylorus, so obstruction, stasis. What associated conditions are seen in a child of IHPS? 1. Firstborn male child. 2. Erythromycin use. Clinical features of IHPS. Onset after 3 weeks of birth. Vomiting, non-bilirubin. Epigastric swelling, olive shape. Visible gastric peristalsis after feed. Dehydration. Electrolyte imbalance. Electrolyte imbalance in IHPS. Hypokalemia, hypochloremia, loss of H+ metabolic alkalosis. But not an H+ excreted in urine, so paradoxical aciduria. Investigation in IHPS. IOC, ultrasound pyloric muscle wall thickness greater than 4 mm. And pyloric channel length greater than 16 mm. Barium contrast study, string sign. Management of IHPS. 1. Correct dehydration and electrolyte by IV fluids. 2. Surgery, Ramstedt pyloromyotomy. Duodenal atresia pathology and most common association. Failure of recanalization of duodenal lumen. Seen in 30% of Down syndrome babies. Clinical features of duodenal atresia. Polyhydramnios. Bilious vomit. Type of duodenal atresia. Type 1 mucosal web, windsock deformity. Type 2 atretic ends connected by fibrous band. Type 3 disconnected atretic ends. Investigation of duodenal atresia. 1. X-ray, double bubble sign. 2. USG, IOC. Treatment of duodenal atresia. Duodenostomy, duodenojejunotomy. Intussusception, age of onset, most common site and main pathology. Pathology, telescoping, of bowel. Age -6 months to 2 years. Site M.C., ileocolic junction. Intussusception is mostly secondary to few conditions, like viral infection, complementary feelings, vaccinations. May also be associated with Meckel's diverticulum. Triads seen in intussusception. 1. Abdominal pain, paroxysmal, colici, sudden, knee to chest pose. 2. Vomit cause of obstruction. 3. Sausage-shaped abdominal mass on right upper quadrant. 4. Current jelly, stool. Investigation for intussusception. 1. IOC USG, donut sign or target sign seen. 2. Color Doppler for vascularity assessment. 3. Barium contrast enema, claw sign. Treatment of intussusception. 1. USG guided reduction by either hydrostat with saline, contrast media, aerostat with air, overnight observation, cause can recur. 2. Surgical resuction. Most common cause of intestinal obstruction in 5 months to 3 years. Intussusception. Most common cause of lower intestinal obstruction in infants. Hirschsprung disease. Pathology in Hirschsprung disease. It's congenital condition, where due to failure of migration of neurons from neural crest, result in a ganglionosis in submucosal and myenteric Auerbach's plexus. Basically absence of parasympathetic ganglionic cells in distal bowel and rectum. Most common association with Hirschsprung. Down syndrome, although this disease usually occurs in isolation. Consequence of Hirschsprung disease. A ganglionic segment of bowel doesn't relax on peristalsis, leads to narrowing of bowel, stools can't pass. Clinical features of Hirschsprung disease. 1. Delayed meconium passage greater than 48 hours. 2. Abdominal distension. 3. On rectal exam, normal sphincter but narrow lumen. 4. On removal by finger, sudden expulsion of meconium. Investigation in Hirschsprung disease. 1. Rectal biopsy IOC confirms diagnosis, ganglions are absent. Nerve fibers stained with acetylcholinesterase shows hypertrophy. 2. Plain X-ray and barium swallow. 3. Rectal manometry absence of recto-anal inhibitory reflex. Treatment of Hirschsprung. If early presentation, pull through, procedure, unaffected segment attached to anus. If delayed presentation, colostomy, then pull through.